Good morning, good afternoon, or good evening, depending on where you are. My name is Natalie Giacondo, and I'm the president of MPN Education International. Today, we have a very special guest with us. Her name is Dr. Dana-Farber. She is um, a psychologist and director of sexual health at the Dana-Farber Cancer Institute, and also an associate professor at Harvard. And we've had a lot of interest in our patients and caregivers wanting to know more about their sexual health, something that they've said is not really being addressed by their physicians or healthcare team. So we have Dr. Bober here with us today to present about sexual health and recovery, and then take some questions from you, our listeners. So, Dr. Bober, please join us. Welcome. Thank you so much for being here today.
Pleasure to be here. Thanks for inviting me, and I'm really excited to talk with you about sexual health and sexual recovery. So
Wonderful. Take
let
it
me
away.
just make sure you can see my screen. Um, that look okay?
Perfect.
All right. Thanks so much. Again, thanks for having me, and nice to be with you all. So we're going to just dive right in. And as Natalie said, I appreciate that we hear a lot about health all the time, and we very rarely hear about sexual health. But I really want to sort of start by saying, or make the case, that sexual health is really part of whole person care. It's really just one of the many essential components of quality of life. And I appreciate that it often doesn't get talked about very much. I also really want to start by just acknowledging that there's a very wide range of what is normal, and that this is, again, from my point of view, just a part of the human experience across the lifespan, and that I also realize there are different elements and aspects that are meaningful and important to different folks in different ways, and that's perfectly okay. But really, I think the point here is that for so many of us, it is often the elephant in the room. I always use this slide because it seems to resonate that, we talk about so many other aspects of our experience, and yet this is often, not even on the list. So, without going into a lot of detail about why that is, I really just want to acknowledge that it is a kind of a funny paradox that our culture is so saturated with graphic sexual imagery, but we really have very little real or frank conversation about honest issues. And in the medical context, I will just say that there's often a lot of, I would say, confusion about who is really responsible for starting these conversations. And lots of times, providers will tell us that they assume that everything's fine if patients don't bring it up, and patients tell us routinely that they're not going to start this conversation unless their provider starts the conversation. And there's often, I think, real challenge around the fact that clinicians, believe it or not, really get pretty much no training in how to talk about sexual health. They might get an hour or two in medical school about like STIs and STD, but really we don't talk about sexual health. So sometimes providers may not be sure what to say when somebody endorses a problem. So given that, I think it is really important, first and foremost, for everyone to be educated about these issues, and then to be able to advocate for them, including starting these conversations with their providers. So let's step back for 1 second before we dive into some of the details, just because I want to really sort of clarify my perspective on what is sexual health, meaning that it is really a broad experience that is exactly at the intersection, right, of physical and psychological and interpersonal variables. It is not only about hormones or only about how we feel. And then there's a healthy dose of what we think of as what we call sociocultural issues, right? What we've learned from our culture, our parents, our context. And all of those aspects, right? Physiology, psychology, interpersonal, can really be incredibly disrupted in the context of medical treatment and treatment for cancer and cancer-related issues. So whether this is, body changes, actual physical alterations, alterations, hormonal changes, pain or fatigue, whether it is how we think or feel about ourselves, the kind of negative thinking or distress that goes with loss of body image, for example, the changes that happen in a relationship in terms of communication, right? In terms of fear of intimacy, if all of a sudden something that was comfortable or pleasurable might have pain or discomfort, and just what it means to feel whole, to feel comfortable in oneself when things are different than they used to be. All of those aspects of sexual health are potentially disrupted in the context of treatment. So again, the point here is that every type of cancer-related treatment really has potential to have a pretty big impact on sexuality and intimacy. So these are some of the common sexual health problems that I want to talk about today. I want to talk about symptoms of menopause. I want to talk about decreased desire, loss of sexual activity, loss of sexual satisfaction, changes in relationship stress, role changes, psychological distress that goes with all of that, and what it means to just have a loss of body image, right? Of sensation of body, a sense of integrity, feeling whole in your body. These are common problems that we often hear about. So really sort of focusing on women's health and women's sexual health, I really have to start with what we call vaginal health. And that is really because this is a topic that is relevant for everyone, or everyone, I should say, that has a vagina, but it does not get talked about. And just to be clear, when we're talking about vaginal health, we're talking about the genitals that are both internal, what we call the vagina, which is actually the internal canal, and the vulva, what's external. And the reality is that for all women, there is often a point in time where we start to lose estrogen. And the changes after estrogen loss, they may be promoted by treatment, right? Treatment-induced menopause, or treatments that intensify or exacerbate menopause. But what that really means is that we're talking about estrogen loss. And I want to be very clear about what that means in the context of vaginal health. So what we know is that there are significant changes in terms of loss of blood flow, change in balance and pH. We lose elasticity. Women are often at that point prone to more inflammation, let's say, or infection if that tissue gets very thin from that loss of estrogen, and there may be pain or discomfort with sexual activity. Externally, we also see change in loss of collagen, and we know that when the ovaries are no longer working, which is really the definition of menopause, the ovaries are no longer producing estrogen. We also know that ovarian production also means about half of our testosterone is lost as well. And what people often don't realize is that change after that estrogen loss also has a big impact on urinary function. So women may notice that we have more urgency or frequency or even urinary tract infection. And together, all of those symptoms are really clustered in a category of what we call the genitourinary symptoms of menopause, or for short, genitourinary syndrome of menopause, what we often call GSM. So again, GSM is something that affects millions of women, and especially in the context of a medical treatment, cancer treatment, those symptoms are often really intensified or exacerbated. So thinking about recovery for vulvovaginal health, we really think about how to increase moisture, stretch, and blood flow to that tissue. This is something that I would say all women really need to learn about in terms of recovery for sexual and vaginal health. So I want to talk very briefly about some of the basics. I think that often women are not informed about the difference between what we call lubricants and moisturizers. Vaginal moisturizers are a category that are often over-the-counter, non-prescription, but different than a lubricant. This is a product that is really meant to hold water in the tissue, similar to what you might put on your hands or your face before you go to bed at night, but again, formulated for vaginal health. People need to moisturize internally, and we need to moisturize externally, around the opening of the vagina. And there are different kinds of vaginal moisturizers. I'm certainly not here to sell products, but I will say that there are a number of products now that are using what is called hyaluronic acid. This is a molecule that holds water in our body. Lots of dermatology companies have hyaluronic-based products, and there are now vaginal moisturizers that do as well. But this is a very important part of, I would say, regular kind of maintenance for keeping that tissue healthy, for keeping the pH balance, for keeping moisture in the tissue. There are certainly vaginal moisturizers that are not over the counter that are classified in the category of hormone-based moisturizers. Typically, that is either vaginal estrogen or what we call DHEA, which is also a precursor to estrogen. Again, not menopause management in terms of all over hormone replacement, but this is local hormone that really is held in that genital tissue. Really important to know about this product, especially if over-the-counter products are not adequate. Vaginal dryness is something that is probably one of the most distressing problems around related to menopause with or without sexual activity, right? Women often have pain, discomfort, again, not only with sexual activity. And just to be aware, these kinds of products, vaginal estrogen or DHEA, can be delivered in different ways, whether that's a tablet, a ring, a cream, and you can certainly speak with a gynecologist or a provider about that. But it's really important to sort of make these decisions again with a medical provider. But I'm often struck by the fact that people really are struggling with issues like vaginal dryness and just don't get the help that they need. I would also say an important part of learning about vaginal health and sexual recovery also has to do with learning about the pelvic floor. This is something that we really don't hear a lot about. The pelvic floor really refers to that basket weave of muscles that sort of stretches from like a sling from the tailbone to the pubic bone, front to back. And those muscles can really lose tone and elasticity as we age, as we go through menopause and other treatments that intensify menopause, and the ability to be able to both keep those muscles toned when you need them to be engaged and to keep those muscles relaxed when you want them to be relaxed. That sort of flexibility often gets lost as we move from mid-age and beyond. So I would say that just to go back to that, it is not only about sexual recovery. I really also see this about being able to get a GYN exam comfortably, being able to ride a bike or exercise without discomfort. I want to point out that when women have either some pelvic floor dysfunction, those pelvic floor muscles are too tight and sort of over engaged, or have that loss of flexibility with vaginal dryness, that often leads to pain or discomfort. And it is very often quick that we sort of find that women are in a kind of a cycle of pain. That's called vaginismus. So I just want to point that out, that for anyone who may be struggling with this or who has had any kind of pain or discomfort with sexual activity, it very quickly can lead to a sort of involuntary reaction where the body sort of tenses up and braces for the anticipation, with the anticipation of pain or discomfort. This can certainly make sex or sexual activity more uncomfortable. If it's painful, it sort of reinforces that cycle. We sort of avoid wanting to do that, but it's really that anticipation and involuntary muscle tension, which really often becomes quickly a kind of a cycle of pain that we really need to address. And no one should be having to deal with any kind of pain or discomfort with sexual activity as the price that we pay. I would say that's something we can absolutely address, and that should not be something that we have to live with. So I really want to make clear for everyone that when we think about pelvic floor dysfunction or these issues related to menopause, there is a lot of recovery and rehabilitation strategies that are available. Again, often we don't talk a lot about this, but I want to just give you a quick overview. There are lots of ways that we can first and foremost help that pelvic floor muscle relax. We can certainly sort of do work that is both kind of physical and hands-on to be able to help women learn how to relax the pelvic floor muscles, how to gently get some stretch or elasticity back to that tissue. You can see there are a number of sort of images on this slide, including a set of cylinders. Those are called vaginal dilators. Now, in this case, these dilators are static. They don't buzz or vibrate, but really just in a kind of a systematic way in using different sizes. Women can learn to mechanically gently stretch that tissue and begin to relax those pelvic floor muscles. There's pelvic floor work. There's everything from yoga to what we call pelvic floor physical therapy. There is a whole branch of physical therapy by folks who are experts just on those pelvic floor muscles, can do both some manual physical work as well as give folks home-based exercises to, all kinds of things that we can do. have a few pictures there of vibrators. I will just say that I'm a big fan. We know that vibration therapy, both for actually for men and women, has incredible therapeutic value for those pelvic floor muscles. It gets nerves firing and blood flowing, and can also, again, be really quite therapeutic. So again, lots of issues, but also lots of strategies to be able to help restore the pelvic floor. So again, this point here of the vibration slide is just to say that vibrators we use all the time or recommend them as being useful, not just for pleasure, but also for therapy. And again, the point here for women's health, we know that it not only can enhance blood flow, but really can help muscles relax and elongate the canal. And bottom line, can really increase lubrication and decrease pain. So again, just sort of thinking broadly, not just to only focus on pleasure, which is really important, but to recognize that there's a therapeutic value to many of these strategies as well. I want to talk for a second about low desire. This is probably the most common issue that is reported by women in the context of any kind of treatment, cancer-related treatment, or quite honestly after menopause. And I also want to sort of acknowledge that symptom, that syndrome again, if women are having any dryness or discomfort, if there's pain with sexual activity, there's that automatic clenching. And that pretty quickly really leads us to a situation where we have low desire. So again, any kind of anxiety or fear or distress related to sexual activity is going to be a pretty big reason why people want to avoid something that's uncomfortable, and obviously going to make an impact around desire. So for that reason alone, I think it's really important to make sure that that genital tissue is healthy and people are not struggling with any of those issues around discomfort or dryness. First and foremost, really important. Thinking also about some of the options that we have in terms of the medical side, pharmacologic side. You can see on this slide, I sort of mentioned again, as I said, estrogen, DHEA. We know those options work well. I will just quickly comment that there's a lot of focus on what we call the laser treatment. Maybe people have heard or read about that, the Mona Lisa laser, in the context of women post-menopause with after any kind of cancer treatment. To be honest, we really don't have any good evidence that that works. It is expensive, it is off-label, not paid for by insurance. And I would say, at least from where we sit at the Dana-Farber, we do not and cannot recommend the laser for vaginal rejuvenation as an evidence-based treatment. I would say it is, the jury is still out at best. I do want to talk about low desire for a little bit more, but specifically, I would say there are two medications that are currently FDA approved for low desire, flibanserin and bremelanotide. Both focus on different aspects of serotonin and other receptors. Helpful for some people, for about 50% of folks, not much different than placebo, sugar pill. So again, I wouldn't say that they don't work, but I would say they are variable, do not work for everyone, and we don't have a great understanding about why that might be the case. So I'm going to give you some other thoughts about that. My point, though, is that recovery, sexual recovery and sexuality is not only physical. We really have to think a lot about the mind-body connection. We really have to think a lot about body image and about relationship and dynamics. Those are all such important aspects or pieces of the puzzle. So I want to talk about low desire for 1 second, because often the thought is that you either have it or you don't, and we really think of it like a light switch. I would say that that notion around desire is much more relevant to when we are young, and it is very different as we sort of move through midlife and beyond. We know that when we move through midlife and beyond, for most people, most of the time, desire is not automatic like a light switch where it's on or off, and that it is often not spontaneous, right? We have a term for that. We really think of that as what we call responsive desire, meaning that desire typically as we age becomes an experience that we have to create, that really emerges out of an experience that feels exciting or sensual or connected. It is not like a light switch, and that is normal. I would say that is probably one of the biggest sort of pieces of misinformation that we sort of get from watching TV and movies where it is always spontaneous. I always like to say that, sometimes that might be the case if the stars align and you're on vacation and everything is perfectly, relaxed and easy. But for most folks, that's not the case most of the time. It's something that we really have to cultivate. It's not something that we expect to be automatic. We really think of that again as called responsive desire. So I have this image because a patient said to me recently, "Oh, you mean like a piece of toast?" And I said, "What do you mean?" And she said, "Well, you have to you put the bread in the toaster, it has to warm up before it pops," which I thought was an apt metaphor. So I'm going to give you a couple of examples that I like a lot. One has to do with that sort of experience when you go to a restaurant, you have a lovely dinner, you feel full, you're really not hungry for dessert, and then all of a sudden a waiter walks by with a lava cake that is absolutely gooey and delicious, and you smell it, and all of a sudden your mouth starts to water, and you think, wait a minute, maybe I could have a bite of that. Other option I think about is that notion of desire for exercise, right? Where it might be early in the morning, it might be cold or raining, and the feeling automatically is I have no interest in getting out of bed. But we know that once you actually start to move, right, people feel better and then feel more motivated to keep going. And in both cases, you really have to kind of have an experience that primes the pump and allows you to sort of cultivate an experience that you then react to. So I think the idea of anticipation is really helpful rather than assuming desire is spontaneous. I think in the context of cancer treatment and medical treatments in general, where we really have to often rewrite our script and think about kind of new habits or new experiences that allow us to experiment with how to cultivate a desire rather than just expect to have it, whether you do or you don't, but you really think about how you build that experience in a different kind of way. So I will quickly say that when I think about that mind-body connection, that sort of thought-feeling connection, that's a big one when it comes to sexual recovery, meaning that lots of times the assumption is that it's not on my mind, I don't think about it, and I don't care. I often think that, if we dig a little bit, what we realize is that there's often a kind of a tape loop. I sort of have the old-fashioned cassette tape there because that's my age, but as my research assistants point out, you could use the loop metaphor. The concept here being that lots of us have thoughts and feelings that are sort of like a loop that you press play and all kinds of thoughts go through our head, not feeling attractive anymore, feeling old, not feeling that somebody's going to want to date you or be attracted to you if bodies have changed in some way because of treatment. And the fact is those kinds of loops really have an impact on those thoughts, have an impact on how we feel. It is really important to be able to think about the connection of thoughts and feelings because often those thoughts are automatic and they really drive a lot of how we feel out of our awareness. So give you an example, some of the work that often has to get done is to learn how to, one, identify what those negative thoughts are and to be able to talk back to them, right? Often the way we talk to ourselves is never what we would allow if we heard a friend say something out loud, right? We might say to a friend, wait a minute, hold on, there must be another way to think about that, or I don't think that's true, or, that actually is not really fair to yourself. You've been through a lot. I think you need to give yourself a break. But we often wouldn't say that to ourselves. And the reality is our own negative thoughts largely often have to be challenged similarly. I'm going to talk for one quick second about the notion of avoidance, because I think when it comes to sexual health in general, especially as we move through midlife and beyond, and things are different or distressing, the automatic place we go after we might feel some distress and have some of that negative self-talk is to avoid the whole thing, right? To either make sure we are just kind of going to bed at a different time than our partners, or to sort of not talk about it or distract ourselves. And the fact is, in the short term, when we avoid those kinds of interactions, we feel better because it's a relief. But avoidance is a big problem because it is a very powerful reinforcer of itself. And the more we avoid anything, the more we have an immediate experience that actually it's something we have to avoid, right? It actually increases anxiety in the long term. So when we think about sexual recovery in the context of midlife or menopause or cancer, I think it's also really important to recognize that often we have to not just notice that avoidance, but find a way to move through that. So whether that means literally being able to tolerate some of that distress or discomfort, really reframing how we talk to ourselves or how we talk with our partners, and figuring out different kinds of activities, actions, habits that allow us to try something different and create a new chapter. It's really important, but recognizing that often avoidance is playing a role when we are feeling sort of stuck in some way. So in terms of the interpersonal piece, I will just comment that, even when relationships are really close and solid, there can be all kinds of disruption around sexuality. Survivors of cancer, folks that are going through treatment often feel like things are just different than they used to be. People often feel stressed or guilty that they're not meeting partners' needs. And when we certainly feel guilty, it doesn't exactly feel romantic. When sexual activity feels like a chore, right? It does not feel pleasurable. It is not something that we may want to approach. And I think that, again, for anyone, pressure or guilt or pain don't feel good individually. They're not a turn on for ourselves, right? And it's really important to be able to really sort of figure out what has changed, what might be different, and what we need to do to address those changes. So I would say in general, when I think about sexual health and sexual recovery, I often talk about relationships, right? I often meet with couples. We talk about relationship recovery, where people really need to be able to not just clarify the goals together and their expectations. Often we may need to do something like improve communication or figure out what are the shared goals, what are the ways that goals may be different than they were 10 years ago or 20 years ago, and what they are right now. I think it's important to help couples start slow without actually being achievement oriented. I shouldn't say goal oriented, but necessarily achievement oriented, where the focus is really on what feels good, what is pleasurable, what feels sensual, what couples may be able to do, let's say, to expand the repertoire, right? So instead of being stuck in a routine or feeling like if I can't do what I used to do, then we can't do anything, I often talk about the notion of how it is important to start dating again, to create a new chapter, which I recognize might seem kind of awkward or funny if you've been with a partner for a long time, right? But there is often exactly that need, right? To be able to create some new experiences, which may feel awkward or may feel uncomfortable. But the good news is that if you trust your partner, if you care about each other, and you can kind of rely on each other's having sort of best intention, in mind to want to be caring and kind, there's a lot of room for experimenting, and I think that can be incredibly important. So, again, whether that is also with a little bit of help. Sometimes couples find it useful to have some sessions with a counselor, or maybe that's something people do, within a couple without external support. But often the relationship piece is a really important piece of sexual recovery in general. I want to say for a quick minute that I don't think we talk about body image enough, and I'm not just talking about what one looks like externally, but the experience people have of feeling whole, of feeling a sense of integrity and wholeness in their body. Often we don't have a lot of compassion for ourselves in that way. And I recognize that it is important to cultivate a sense of kindness, even when things are different, when treatments leave us feeling tired or sick or with a less sense of vitality. It is important to be able to focus on what you can do, where you can feel strong, and really to recognize that when I'm talking about body image, I am not talking about a body part, but I'm really talking about what it means to feel a sense of integrity, what it means to feel comfortable in a body that may be different than it used to be. So again, there is a reimagining here, and a kind of a creativity here where, again, I think the concept of a new chapter can be useful. So all in all, I really want to kind of underscore the point here that sexual health, sexual recovery is not something that typically gets better or improves by itself. It's something that needs care. We typically need to be proactive. And sexual problems, in particular, sexual function problems, do not get better by themselves typically. Often we know that those issues are sort of track closely with anxiety and relationship distress. But I can't underscore enough that if there is anything that has been that is different for you, that's something that you really want to address, it's really important to be able to, be educated enough to know what questions to ask, and to feel like you can ask. And I really want to underscore the point here again. We've done so many surveys with providers, medical providers, oncology providers. They're clear when they say, I'm nervous about starting the conversation. I lecture to oncology providers all the time who say, I don't want to make my patients uncomfortable. And patients say, well, I don't want to make my doctor uncomfortable. And then we sort of have that, again, the elephant in the room. But being an advocate for, I think, for this part of one's experience, if this is something that's changed or different, I don't think is any different than anything else on the list that really deserves care. So I would say from a big picture perspective, I'm heartened to know that there are really more accesses, more resources and sort of educational sort of resources out there now for anything related to menopause, cancer treatments, cancer-related treatment, than we've had before. I mean, that's something that has really changed in the last decade. And I would just say that there are really good quality, high quality resources available. So don't be shy to look into some of that. And I think, going and starting with sort of high quality patient advocacy websites and websites like the NIH and the American Cancer Society have some good resources there. So again, talk with your team if there's something bothersome or distressing. You can ask on your team, is there someone else I should be talking to, right? Who would be a good person to speak with? And please don't be afraid to advocate until you get what you need. So I think the take home message for me when I speak about sexual recovery is that first and foremost, if this is something that is changed or bothersome in some way, we can make it better. If we can identify what's going on and be able to figure out what the goals are, we really can sort of frame a new course and figure out how to focus on curiosity and pleasure, and sensuality, and really sort of help people experiment with what we can do to improve things, and to really commit to a plan of action. Because again, being sort of not being proactive is probably not going to be the most useful way to go. So that being said, I'm happy to be here with you today, share a little bit of what I do at the Dana-Farber, and happy to take any questions. Thank you.
Thank you so much, Dr. Bober. I mean, that was incredibly informative. And really, as you said, it's something that everybody could benefit from, not just people who are experiencing or the impact of cancer or their caregivers. So interestingly, we usually get quite a few questions going through someone's presentation. And I think the topic may be something that is a little bit difficult for people to discuss. So I have a few questions. I'm getting a few now. Just a reminder to the people who are listening today that you're allowed to either submit a question to the question answer section down there at the bottom along your Zoom screen, or to our chat, and you can speak directly to Dr. Bober. I have one here, and again, I've got my own questions, but I'm going to take questions from our audience first. The American Cancer Society literature on serial health is very off-putting. Your conversation is more welcoming. How concerned do we need to be about our immunity levels and infection from sexual activity to have safer sex? How concerned do we need to be about sexual activity, skin integrity, and unintended friction trauma? So that's a couple questions there.
Okay, so those are good questions. So I appreciate that, for sure. I think everybody has their own experience around, what's going to be. First of all, thank you for saying my talk was welcoming. I appreciate that feedback. But I appreciate that, there are really a range of different kinds of resources. I will say that, in terms of immunity and infection, generally speaking, right? I think that in the same way that people really need to be aware of what is acceptable and is feels comfortable in terms of any kind of immunity issues is going to be also relevant, right, to sexual health. So if people know that they are immunocompromised, right, and need to be conscientious about that, it's going to make sense that if you are exchanging any body fluid with anyone, including in the context of sexual health, you want to make sure that people aren't sick, that people don't have a cold, that you're using the same basic kinds of protection infections. I also appreciate that if we're talking literally at the level of being either neutropenic or having, a very significant infection risk, it would be something that you want to, be aware of, right, in terms of what is safe. And I think that's best asked to your oncologist. But that being said, I will say that what I'm often struck by is that, assuming that, you're using good hygiene, assuming that you and your partner are familiar with each other and you are not, sick, flu, cold, etc., in general, sexual activity is not something that is dangerous, right? And so, I think that, often there is concern about, that I can't have any touch at all or exchange any body fluid at all. And I would say that is, from what we know, that is often not the case, especially if we're talking about people who are not having very severe or significant immunocompromise. So that would be something to certainly talk with the team about. And I think that there was a question there about skin integrity. And again, just being aware of how to use, high quality, good quality lubrication. A lubricant separate in addition to a vaginal moisturizer is very important. I would just say paying attention and knowing that, if there is skin breakdown, who you can go to. Is there a dermatologist that you can work with? In the same way that you might be talking to a dermatologist about anything else, there are derm folks who concentrate on GYN care. So I would just say that what I'm often struck by is that because of some of these issues, people often end up having no contact, right? And that is not necessarily the way to go. There may be a sort of creative option with a partner about things you may do or you may not do, or that you may choose not to have certain kinds of sexual activity, but that does not mean you don't have any sexuality at all, right? It's not all or nothing. So I think that's an important perspective. I see that there are a couple of questions about UTIs and urination. I am not a gynecologist or Urogyne, but I spend a lot of time with my gynecology menopause colleagues, and I will say that for any woman who is having regular UTIs, it is very important to figure out what's going on there. And often use of vaginal estrogen is critically helpful, probably one of the most important tools we have. There are a number of highly respected women's health folks who would say that every woman pretty much in menopause should be on vaginal estrogen. It is incredibly powerful in terms of being able to keep that tissue healthy, and in terms of being able to reduce infection. And I will say that there's a growing understanding that UTIs can be life-threatening, right? I mean, we know that that is not a minor problem. We also know that being on constant antibiotics has a lot of downside as well. So, and I will say there are other things like, BV, right? Bacteria vaginitis that can mimic what feels like a UTI, and again, largely because the microbiome of the vagina gets thrown off in menopause when that pH is out of balance. All of those things can be addressed directly with vaginal estrogen, and so it is absolutely worth a conversation. And that is something which is often overlooked, but incredibly, incredibly helpful.
It seems that one of the, concepts that you keep coming back to is communication and planning. So I know that's something that, a lot of our patients have bleeding or clotting that is not typical in the general population. And so these questions about UTIs and skin integrity and stuff like that are probably somewhat fueled by those concerns. And just, you keep saying, communication with your physician, communication with your healthcare team, communication with your partner. So thank you for that.
Absolutely. And also just recognizing that, I see there's a question about bleeding with urination, that I am not a hematologist. I don't know, if that is more relevant to a proliferative disorder rather than to menopause, right? But I would say that it is worth sort of addressing with somebody who knows, right? And I'm a huge on recommending people get second and third opinions, right, if they need to. I also think that, if you don't get an answer, it doesn't mean that there's not an answer. It just means that person might not know it. So I think that, and I really want to point out that there are a number of practitioners now that are menopause certified practitioners, not even, going over and beyond sort of general GYN. And it might be really worth getting on the Menopause Society website to look up a certified menopause provider in order to sort of track down an answer for a question like that.
Great, thank you so much. There is a question about sharing your PowerPoint slides, and I know that can would you consider sharing these slides
Sure.
or
Yeah, yeah,
some
yeah.
of
No,
them?
I'm totally happy to. I will
Okay,
send you I can send you a PDF, and you're
great.
welcome to distribute those.
Perfect. Also, I know you spoke about body image a little bit, and some of our patients really experience sort of debilitating fatigue. And I
Mhm.
wonder if that could be part of sort of your concept of who you are in terms of your body and how it functions and how you might
Absolutely.
address something like that.
Yeah, absolutely. And I really tried to make that point because I know that, again, when we hear about body image, I should use, I don't know, I should use that term. I should just talk about body integrity because I think the experience of just feeling whole, right? The feeling of feeling comfortable in your body changes so much, right? In the context of these kinds of treatments and changes. And, fatigue is something that is affects everything all the time and really is not obvious in terms of how you look when you're walking down the street. So, often does not get the attention that it needs. But I would say this is where, in the context of I would say sensuality or sexuality in general, it's a great example of where people need to get creative, right? And so, recognizing that, trying to, kind of have a date with your partner at, 10 o'clock on Saturday night is just probably not going to work anymore, or it might not work anymore, that people really need to be willing to, be creative around, weekends or mornings. And I know that when you're younger and you have kids at home, it gets complicated, right? I mean, it's funny when you spend a lot of time when kids are really little and you're going, was at night versus the morning. And then all of a sudden when you have teenagers, the morning versus the night, because they're up later than you. So I recognize that parenting and maintaining intimacy with a partner often have to be sort of strategic. But this is where I think it's important to, be honest with the partner and communicate. And I don't think that the answer is, well, I'm just too tired, I can never do this again. I will say, like anything, whether where we're talking about exercise or walking or movement, we know that the key is to figure out the right balance, right? And that often paradoxically having some more experience can sort of build muscle in that way. And I don't mean just sort of physical muscle, but the mental muscle of how to do something is activating, but it has to be right for you, right? And so just appreciating that the fatigue piece is really under acknowledged in terms of how the impact is on sexuality and sensuality. And I really do believe it's something that people can be creative about, right? And again, I'm going to point out that when I'm talking about sex and sexual recovery, I am not only talking about, oh, we're having penetrative intercourse. I think that is not always possible. I think that is not always on the top of the list, but being able to find ways to maintain connection, intimacy, sensuality that is different than just making dinner or going to a movie, right? Something that you don't do with everybody else is actually, I would say, for many people, one of the things that allows them to feel more energy, right? That can actually be can improve quality of life, but it doesn't. If a partner is thinking, well, I don't have the energy for that, and they're thinking kind of all or nothing, or they're thinking my partner's going to be disappointed if we start something and I can't finish. I hear that all the time, so that means I can't start at all. Like a lot of that is stuff that can get worked through as a couple in a more creative way if there's a conversation about it, right? And so I'm always really trying to advocate for being able to say stuff that we might be thinking in our head, but we're not totally sure about, but we're quite convinced that what our partner's thinking, and really be able to recognize that there often might be a room there for some other kinds of ways of doing things.
I love that you keep focusing on solution so that here's the issue, but it's not a roadblock. It doesn't mean the end of this. We're not going to just stop. We're going to talk about it and try something, be creative, be
Yeah,
playful.
yeah.
That's,
I'm just looking at the last comment and I
yeah,
realized that we didn't make it clear that this was going to be about women's sexual health. And I apologize because I think there was probably a little bit of a disconnect there,
yeah,
and question about male patients. So I'm so sorry. I just sort of had that thought as soon as I got started that I thought, oh my goodness, I don't think we made that clear.
we did it.
Um,
And I apologize for that as well. Yeah, we should have been more clear about that.
but to be clear, I see a ton of men. I'd be very happy to do, if you would be helpful at some point, talk about male sexual health. But I would also say that, I appreciate that some of these things are similar, some of these things are different, right? And so, I think what we obviously didn't talk about today very specifically is erectile dysfunction and what that means, if you can't get an erection or can't maintain an erection. There are a lot of issues there, but there are also a lot of solutions there. And it is not only just about the little blue pill. We have other strategies. So that would be something potentially for another talk. So I see that question about vaginal estrogen and blood clotting issues. Again, this is where I am really conscientious about not giving medical advice. I think that there are many, many people who are able to use vaginal estrogen. It is in contrast to estrogen replacement therapy in the context of what is safe around clotting, but I would absolutely speak with your doctor about that directly. For women who are not able or who do not want to use vaginal estrogen, I would strongly recommend a really good solid vaginal moisturizer that can certainly at least help with moisture, balance pH, and address many of the same issues. Might not be the same, but can be really, really helpful. And in terms of pelvic floor physical therapy, it is honestly for men and women one of the most effective and helpful modalities that nobody knows about. Pelvic floor PT is essentially a type of physical therapy that is paid for by, if your insurance pays for PT, it pays for pelvic PT. It's just another kind of specialty within the PT world. I would say in terms of making a referral, I don't know. I mean, typically, what we find is that either we send people to or patients seek out a PT and then they'll call their primary care to get a referral. Not all primary care doctors may even know who's a local pelvic floor PT person. My comment I want to make about this in general is that it's really important that the people who do the pelvic floor work are incredible, amazing at what they do, but they have very specialized training. So it's just important that you're not seeing a general PT who says, oh yeah, I can do that pelvic floor piece. You really need to know that they are trained and certified to do that work. And that's an important distinction. If you look up pelvic floor PT, if you Google that, I believe that there is an organization that coordinates pelvic PT practices. And the other thing is that if you go to any solid, well-respected PT group and you ask them who in the community does pelvic floor work, presumably if they don't have someone in-house, they will know who in the community does that work.
Excellent. Thank you so much. Let's see, there's another question. We're going to take a couple more questions and then we'll wrap things up here. So, suggestions about relationships after a heart attack.
So that is a really common question, and I would say first and foremost, people often worry about just what is safe and what is acceptable in terms of what may be too much exertion. I think first and foremost, it's just really important to ask your cardiologist about that, because if you have any restrictions, you want to know. Often people do not, and are just afraid, and which is understandable. But I think that starting with kind of guidance from your medical team in terms of what is and is not acceptable is the first place. And then in terms of the relationship piece, I think that often it's just important to start slow, right, and to figure out what feels okay. I don't think that people have to go straight to, again, no contact to penetrative intercourse and have it be the same. I think it can often be, one of the helpful things about getting to midlife and beyond is that nobody's going to go blind or go crazy if they have an erection and don't have a immediately have a, experience of orgasm or whatnot. There are a lot of options in terms of being able to kind of just figure out what kind of touch, what kind of sensation feels pleasurable, what allows you to sort of breathe and feel like you can, kind of experience and have an experience without getting panicky or nervous. And often it's just important to take your time doing that. And often partners have no idea what's acceptable or not. So like start out with asking a doctor, are there any restrictions? Is that something I can do? And go from there. In terms of the last question, I just appreciate the comment. So thanks for that comment. Yeah, and so in terms of erection meds with the partner, again, we know that with the oral medications, what are called the PD5 inhibitors, so the Cialis and Viagra, are what people hear about most, and they are often ubiquitous. Important to talk with your doctor about that. I will say sometimes those meds do not work, or do not work well enough, and we know that there are a number of ways to get medication to that penile tissue that will allow for blood flow to flow into that tissue more effectively. There are also non-pharmacologic options in terms of being able to use what's called a vacuum erection device or a pump, etc. Again, happy to talk more about male sexual health another time, but to say that, again, it's really important that just people are educated about what kinds of options are, what I would say, evidence-based, what versus the kind of snake oil that's being sold. And I am struck by the billion-dollar industry we have where people are targeting men, especially men of mid-age and beyond, to buy all kinds of things to help with erections that really don't work. So, I'm thinking about what we hear about, like, for example, shockwave therapy, the kind of stuff that you can do at home or in your doctor's office for a lot of money, and we have no evidence that it works at all. So it's just important to be able to separate out what's kind of good quality treatment that we can expect to work versus what is kind of marketing.
Thank you for bringing attention to those sort of snake oil treatments. It's a good thing to let people know to be cautious about.
Yeah.
And we hope that you will join us again and speak specifically about male health issues regarding, their male sexual health. I have a feeling that we're going to have a lot of questions after we leave this webinar today. This will go up on our YouTube channel, and so we often get questions from patients weeks and months after something
Sure.
like this. So I hope that we can continue to reach out to you. This was an incredibly informative and useful conversation, one that so many of our patients have asked for, and I really appreciate your time today.
No, thanks for having me.
Yeah, thank you so much. And I'm just going to remind our viewers today that we do have a live event in Charlotte, North Carolina, August 21st. And we hope that if you're anywhere in the area that you will come and see us and talk to MPN experts directly about your MPN questions, anything that you may need from us or from your physicians and healthcare team. Also, we will be in New York City for our 11th annual Women and MPNs event this year on September 26th with our newly confirmed special guest, Sally Field. So I hope that you will go online and register for both of those events or either of those events if you haven't had a chance to do so already. And we appreciate Dr. Bober. Thank you everybody for joining us. If you have any other questions, please email us directly. You can find our emails on our website, mpnadvocacy.com. Thanks so much. Have a great day.